Depression and bipolar disorder. So you've already learned a lot about cognitive therapy, and the techniques described in the Judy Beck book focus a lot on techniques that can be used with patients with depression. The seminal book really is Beck, her father Aaron T. Beck's book about cognitive therapy for depression. It's not the most user-friendly book, but that's kind of the one that revolutionized the field of cognitive therapy per se. It's kind of the primer on depression. And so basically you're using a lot of the techniques that have been discussed already, like changing dysfunctional beliefs, etc. So according to Beck in the cognitive model, as you probably already know, Beck believes there's a cognitive triad for depression with people having negative beliefs about themselves, the world, and their future. So oftentimes, like we'll have those depressogenic thoughts like I am no good, those core beliefs, no one loves me, the world is a dangerous place, there's no place here for me, and the future is pretty much hopeless. Just in terms of assessment, hopelessness is one of the best predictors of eventual suicide. So if you have a participant, a client, who talks about being really hopeless, is very bleak about the future, absolutely sees no hope for the future, you want to assess them for suicide, because if they see no point in living, then often the rational conclusion in their minds is death, and so you want to assess them for suicidal ideation and then act accordingly. That's something that you want to monitor. If you have a patient who's coming to you with I would say moderate to severe depression, you may also consider giving them the Beck hopelessness scale as a measure of assessment, because this is something that again is predictive of suicide or suicide attempts, and so you want to kind of keep an eye on that, because sometimes people will admit to hopelessness but they won't admit to suicidal ideation, and just it's a good thing to monitor. So anything above kind of a score of 11 or so on a 20-point scale would indicate a moderate to severe level of hopelessness, and something that you should be addressing in therapy. So as Judy has talked about, and as we've talked about in this course, assessment is really important. And usually when I have a patient who has depression, I give them at least 2 of the 3 following scales, the BDI, the BHS, and depending on whether they are experiencing anxiety or not, possibly the Beck Anxiety Inventory. Each of these takes about 2 or 3 minutes to complete. And you can have them, complete them ahead of time. Patients can have multiple copies. I've provided for you copies in the folder in the CBT series contents folders. And what I'll do, as described in your book, is I'll review these at the beginning of treatment. I'll note it down in the notes, and this is a form of data, but it also is a form of assessment to see if anything's going on. So for example, if my client has been trending downwards in their depression and suddenly there's a big spike, I'll want to know, did something happen this week, what's going on? I also keep an eye on the suicide item, making sure that it's at least constant, and if there's a change, then I will definitely address that. And anytime there's a non-zero level of suicidal ideation, I always would make that a discussion topic in session. So when you're doing cognitive therapy for depression, you're going to use the skills described in the Judy Beck book. Like, it's very collaborative, you're eliciting and challenging negative automatic thoughts, you're doing DTR exercises, you're doing hypothesis testing. You're also simultaneously going to be doing behavioral techniques such as activity scheduling, so getting them out of the house, getting them to do things. And just a word of warning, when I first started doing psychotherapy, I was really into activity scheduling. I thought it was a great idea, so I'd whip out my my calendar for the week, and I'd have the client write down what they were going to do every day, and they were going to do this, 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 and this, and it was all great, and they'd come back the next session and they'd be even more depressed than before. And what I found out is that I was over-scheduling them. You can't go from doing nothing to all of a sudden having an activity-laden and full-packed day. So I think that was kind of an error of a novice therapist. So what you want to do is make sure that whatever you do is realistic. And so again, like the homework, you want to say, what's the probability that you're going to be doing these things this week? And you want to start slow. Maybe it's only one thing they're going to do this next week, and that one thing is very feasible. It might be just get out of bed and put your clothes on. It might be take a shower. It might be go out for a walk. You want to do very basic things. You want to make sure that the probability of success is 90% or greater. You want to do things that are mastery based. Those are things that they just they're doing them. Like, so obviously putting on your clothes, you're not going to derive a tremendous amount of pleasure, but you feel better when you get dressed. I mean, I can attest to that. I've had weekends where I thought it would be great to just stay in my PJs all weekend, and then, by lunchtime on Saturday, you're like, ugh, I feel horrible, you want to take a shower, get dressed, get out. And so similarly, you want to have activities that, your patient can do that show mastery, but you also want pleasurable activities, something that they used to enjoy doing. They may not derive pleasure from it immediately, but they would then start enjoying these activities slowly but surely. For example, if they really enjoyed going to movies previously and they haven't gone for, since they started feeling depressed, one of the goals can be for the week is to go to the movies. Whether they enjoy the movie or not is not necessarily relevant at first, but the fact is they're getting out and they're doing things they previously enjoyed. So I've used this phrase several times already in this course, but you have to fake it until you make it, and that can apply to both the therapist and the client. And so, especially with a depressed client, you want them kind of going through the motions, and eventually, as they start to fill their life up again, they will get less depressed. It's kind of inevitable just by, instead of lying in bed all day or lying on the couch, just by going out and do things, they'll start, getting more pleasure around them. You want to make a weekly activity schedule, and you also want to cognitively rehearse the activities with the individual. So have them, go through calling their friend up on the phone. So it's almost like a role play, except that they're kind of imagining it in their minds, and this is when you assess the feasibility and also the likelihood that they're going to do this. So there's good evidence for cognitive therapy for depression. It's found to be as effective as medication in terms of outcomes. So, a lot of patients prefer to take medication to cognitive therapy, and that's understandable. It's a lot easier to pop a pill than to go to a therapy session once a week for about 15 to 20 weeks. However, what the difference is that therapy is particularly good at preventing relapse. So a lot of people, once they go off the medication, they will often have relapses. And not to say that people who have therapy don't have relapses, but the relapses are deeper with people who are on medication because they're not attributing their improved mood to skills they've learned or empowerment, but rather to the medication. And thus, it's kind of a chronic cycle of they feel depressed, they take medication, they feel better, they stop the medication, they get depressed again, and the cycle continues. And there's some evidence to suggest that subsequent episodes of depression become deeper and harder to treat. That's not always the case, but there's some evidence to suggest that. You also have to prepare your clients, when you're doing therapy, that there is a likelihood that they will relapse or they will feel low again. And so what you want to do is do kind of relapse prevention and have like kind of warning behaviors. So when they start isolating, when they start not finding their favorite movie funny anymore, what are some things they can do? What are some techniques that you practice together that they can apply? This also might be a good time for them to give you a call back up again after you've stopped therapy if they feel like they're sinking back in there before it goes too low. Unfortunately, there is some evidence that suggests that once somebody has a depressive episode, it's called the kindling hypothesis, the likelihood that they'll have a subsequent episode is greater than somebody who's never had a depressive episode to begin with. It just kind of, you've broken the threshold, and now the threshold is a little bit lower, and so the likelihood that they may get depressed in the future is higher. Something that's has become quite popular in the last decade or so is kind of this Eastern philosophy that's become integrated into Western practices. And I think that's kind of as people are looking for meaning in their life, and we get such busy lives that we're kind of not being in the here and now. So one of those applications of Zen kind of Buddhism is mindfulness-based cognitive behavioral therapy. And this was pioneered by Zindel Siegel. He's out of the University of Toronto, and he's written a book. This is a great book if you want to get it. He does a lot of trainings if you have an opportunity to do this. I think it's a great skill to learn. You can read the book. There also is a DVD, which I usually show when I do this class live. Unfortunately, it literally is a DVD, so I can't show it to you. But it's available in the library if you want to take it out. It's mindfulness-based cognitive therapy for depression. And so The central ideas of mindfulness-based cognitive therapy, which I will call MBCT, are intentionality. So you want to bring mindful awareness to thoughts and feelings rather than responding with habitual automatic patterns. Kind of like, how many times have you, had something in front of you, you're eating in front of the TV or the computer, and you ate the whole thing and you don't even realize it. I unfortunately do that with sweets. I love my sweets, and then sometimes I'm watching TV or working on the computer and I've eaten the whole thing and I don't even realize it. I'm like, damn, I wish I had enjoyed that a little bit more. Decentering thoughts and feelings as mental events and not realities. So we often kind of interpret our thoughts and our feelings as reality, kind of emotional reasoning, as Beck would call it. And so kind of understanding that these really are thoughts and beliefs, and to understand them as such, and that they're not really the reality. Reducing experiential avoidance. And so we have a tendency as a culture to kind of avoid difficult situations. When our loved one dies, we're given 3 days to, leave from work, and then we're supposed to return. While we know that it takes, many times years. I'm not saying we should be out of work for years, but that the grieving process does take years. But we expect people to kind of, avoid some of those feelings and get back to normal. So instead, kind of turning towards some of those things, which is kind of an exposure-based technique. So experiencing the emotions, and that allows us to heal. While it might be harder in the moment, the outcome is better, because oftentimes we find that when we repress these difficult emotions, they kind of pop up on us and they never become resolved. And that's kind of the theory behind PTSD. Anti-ruminative, so experiences out of current reality, not of elaborate thinking about its implications. So a lot of people who are depressed tend to ruminate. They tend to focus on things and, create situations for themselves. We're all guilty about this at times. I have to admit myself, I get sometimes, especially if it's, bad news, you get it and you can't get it out of your head. You keep focusing on it. The thoughts keep coming back again and again. And a generic skill, daily practice on non-bodily contact prepares for experience with body image judgment. So keeping the focus on the here and the now, and keeping the mind focused. So MBCT is a very time-limited intervention. It's so we're going to go through the different sessions. The first one, the theme is automatic pilot. So it's identifying and stepping into automatic pilot. This is usually done in a group setting, and so you talk about what it is to be in an MBCT group, and then you do a raise and exercise. You guys are going to be doing as part of your blog exercise, a mindfulness-based exercise, and so in MBCT they have you do the raisin, where each person gets a raisin and you have to look at it, examine it, touch it, feel it, look at the texture, and you do this for a considerable amount of time, just focusing on the raisin, describing it, because it keeps your mind focused on the here and the now, and then you realize that you've never really looked at a raisin in that way before, because we go through life on automatic pilot. How many times have you driven somewhere and you haven't realized that you even got there, because you don't even know the turns that you're making because you're just on such automatic pilot. I know sometimes when I'm a passenger in a car, I look at the scenery of places we've gone many times before, and I just never saw those things before, and so it's kind of interesting. You then do body scans, where it's very similar to the relaxation exercises we practiced earlier. You're focused on different sensations within your body. You talk about incorporating mindfulness in daily activities, and you assign mindfulness homework. In session 2, you start dealing with barriers. You're reacting to everyday events. So you start off the session with a body scan. You go over the homework. People talk about the mindfulness exercise, their thoughts and feelings about it. You schedule pleasant events, so similar to cognitive therapy, and then you do a 10-minute sitting meditation in the group, where you guys just, there's a practice of the skill of meditation. The next one is the mindfulness of breath. So you're maintaining awareness, so you're using breath as an anchor. So here you're doing a 40-minute sitting meditation where the whole group is just kind of focusing on their breath. And as you practice mindfulness, you'll find that it's hard to even do a few minutes sometimes, nonetheless a 40-minute session. People do suggest that mindfulness is a good thing to start your day with, and anywhere from 5 to 10 minutes. So 40 minutes is a long time, and some people feel uncomfortable with it. At the end of that mindfulness session, you do a homework review. You do a 3-minute breathing space exercise where you focus on your breath, and then you do some mindful walking and stretching to keep the mind focused on the here and now, and you assign homework. Session 4 is staying present, where the theme is attachment, aversion, and boredom. You start off again with the 40-minute sitting meditation session. Every time your mind wanders, you want to bring it back to the here and now. We're going to be talking a little bit more about mindfulness when we talk about DBT. You review your homework. You talk about the active experiential avoidance, which, as I discussed earlier, is really how, your mind, we have a tendency to avoid painful thoughts, and as a consequence, they don't get resolved. Like, so we have a fight with somebody and you don't talk about it and you kind of drop it, and it kind of festers there, even though it's not actively something that you're upset about. It's kind of at the back of your mind. You then start defining depression. So this is the first time that you're really talking about the depression. And then there's a videotape that you have as part of the mindfulness-based group, and you assign homework. Session 5 is allowing, letting be. This is kind of accepting one's own experiences. And so kind of being in the moment, and when we have these negative thoughts, to rather embrace them and, understanding that they are thoughts and not reality. Again, you do the 40-minute meditation, homework review, talk about, how you embrace these experiences rather than fighting them, and then you watch the second half of the video and do homework. So you can see this is a very different kind of therapy than the traditional cognitive therapy. It's much more active in the sense that you're doing a lot of mindfulness and practice in group. And so these are, between 1 to 2 hours, these group sessions. Session 6 is continuing on with thoughts are not facts. You again do your 40-minute mindfulness meditation. And then you do a thoughts and alternative viewpoints exercise, discuss decentering, where you kind of focus on, taking the emotions and making sure that they're not real, and then homework. Session 7, how can I best take care of myself? This is preparing for relapse. As we discussed earlier, relapse can kind of be inevitable. And so you list warning signs for relapse and set up action plans, as well as do pleasure and mastery activities. And this is the final session where you talk about what you learned and how to deal with future moods. So you can see that this is a very time-limited intervention. It can often be helpful in conjunction with individual therapy. As you can see that a lot of the individual issues are not addressed. This is kind of teaching some general skills, and I think, helping you with some different techniques. But I think if you want to work on your own interpersonal issues, it probably would be best to do like some adjunctive therapy, some adjunctive cognitive therapy or something of the sort, along with the mindfulness-based treatment. But I think mindfulness is an excellent skill, and MBCT actually has great results, and people are reporting significant decreases in depression after these 8-week sessions. I wanted to talk a little bit about ECT, because it's something that people don't always know about and that's available. So for your patients that are severely depressed, and I'm talking like these are patients that are having trouble getting out of bed, they can't really do anything. These are patients that cannot even participate in therapy because they're feeling so depressed, so kind of almost in a catatonic state. ECT is still around, and it's actually performed daily. And those of you who do internships in hospitals might have the opportunity to go and view it. ECT involves applying brief electrical current to the brain and results in temporary seizures. People usually get 6 to 10 treatments. So we all think of ECT from One Flew Over the Cuckoo's Nest and something that was done a long time ago and was rather inhumane, and they don't do it anymore. But what they do now, actually, is, as I said, is it still goes on. It goes on quite frequently. Is they do unilateral ECT. So before the shock was applied to both hemispheres of the brain. Now it's only done unilaterally, and the person's under general anesthesia. And they're also given a muscle relaxant, so you don't see the spazzing that you would see previously. People also probably know that it's associated with memory loss, although now that it's done unilaterally, the memory loss is much more circumscribed, and it's generally just to issues related to the few hours before and after the ECT treatment. ECT is incredibly effective for cases of severe depression or for treatment-resistant depression. I've seen patients, I had a patient in my group who was literally catatonic, and he went for one ECT treatment, and I saw him a few days later, and it was like this person had come alive. If you've ever seen the movie Awakenings, it's kind of like that. It was unbelievable. The interesting thing is, they're still really unclear as to why ECT works. They know that they're causing a seizure in the brain. There's something to do with neurotransmitters, but it does work, and it kind of jolts the person out of this severe depression. Currently, there are a few side effects. As I said, short-term memory loss is the worst one of them, and the more ECT treatments you go for, the more memory loss you would experience. Now, the downside is that relapse following ECT is common, and that's often because in some cases you're not really dealing with the issues that are underlying there, but it is really good for patients who previously have had a severe depression, and now they're able to participate in treatment and they can work on some of those issues. I also want to talk to you about interpersonal therapy for depression. So this is a more psychodynamically based intervention. It's basically a brief dynamic psychotherapy for depression. It was developed by Claremont and Weissman, who are psychiatrists up at Columbia, and it also has demonstrated very good results in the treatment of depression, and the results are equal to that of cognitive therapy and medication. So I'm just going to go over that briefly with you today. So in an IPT perspective, a person's behavior is viewed as influencing the reactions of people around them, which makes sense. They've done a lot of studies, with spouses and roommates, and when one person is depressed, it really does affect the way people react to them. They actually have found a contagion effect, so that people who have roommates who are depressed become depressed themselves by the end of the semester, or at least exhibit more depressive symptoms. Similarly, spouses develop more depressive symptoms. If you've ever been around somebody who is, moderately to severely depressed, it's no, bowl of laughs. It's actually very difficult because you're trying to interact with them and everything is negative. They don't give you much feedback. And so then you start avoiding them, which then increases their depression. There's some, theory suggesting that people who, develop, or some people who have more of a depressogenic personality style, have these kinds of behaviors or reactions to people, kind of from the get-go, which then influences the way that people react to them. And consequently, they have negative feedback from others, and therefore they feel more socially isolated, they have relationship difficulties, etc. And so these situational factors may lead the individual to become depressed. And so IPT focuses a lot on primary support groups and one-to-one relationships with significant other people. And the focus is on specific interactions and not large social groups or influences. So while cognitive therapy is a more broad-based intervention, here we're talking about your relationship with your mother, your relationship with your significant other, and you discuss issues related to attachment, guilt, bereavement, mourning are paid specific attention to, because oftentimes it's conceptualized using an IPT framework that depression is a result of a severing of a relationship, and so you're mourning, and this depression is this kind of a grief or a bereavement reaction. And so the goals of IPT are to diagnose depression explicitly, to educate the patient and the family about depression, its causes, and the various treatments available for it, to identify the interpersonal context of a depression as it relates to symptom development. So, as I just talked about the different framework, so talking about how, there's how depression can influence interpersonal relationships, and how the loss of these relationships and the isolation resulting from it can cause depression, and then to develop strategies for the patient to follow in coping with the depression. So a course of IPT is divided into 3 parts. The initial sessions are focused on identifying and dealing with depression, including assigning the sick role and evaluating the needs for medication. I really like the sick role, which we'll talk about momentarily, and I use it oftentimes with my patients when I'm working in therapy. Reviewing interpersonal relations with respect to depression, identifying the major problem areas, grief, interpersonal disputes, role transitions, and interpersonal deficits. So you can see there's some overlap here with cognitive therapy and skills-based techniques, and then explaining the background and goals of IPT, similar as you would do with cognitive therapy. So the sick role is based on the notion that illness is not merely a condition, but a social role that affects the attitudes and behaviors of the patient or those around them. The patient is informed that depression will limit their ability to perform well, and they're encouraged to maintain participation in activities in order to help alleviate symptoms and prevent additional problems such as isolation, etc. So why I like this is because, you know, oftentimes when a patient comes to you when they're depressed, they really have withdrawn from society, and they're not really in a place where they're going to have a tremendous amount of success right away. You know, it's going to take them a while to get back on their feet. And so I like the analogy of kind of telling them, like, you know, when you have the flu, people treat you kind of with kid gloves. They coddle you a little bit more. You need a little, you know, extra TLC. You don't push yourself as hard because you're not feeling well. While you know, definitely can do some things for yourself, you are easy on, you take it a little bit easy on yourself. And I tell my patients that, you know, similarly when you're dealing with a depression, it's okay to take it a little bit easy on yourself, because you are dealing, you know, with an illness. And thus, you want to make sure that the patient isn't too hard on themselves. My patients have reported that they found this very helpful, and it kind of, you know, gives them the flexibility of not being so hard on themselves and, you know, as you know, patients with depression generally tend to be pretty hard on themselves, so giving them this ability to kind of, you know, take it a little bit easy and forgive themselves a little bit can be very helpful. So in normal bereavement, a person experiences symptoms such as sadness, disturbed sleep, and difficulty functioning, but these are usually resolved in 2 to 4 months. So as conceptualized in IPT, people are mourning losses, and they're not necessarily losses by death, but losses of relationships, losses of roles, like losing your job, losing your, you know, it could be a transition in life whereby you're going, you know, kind of from middle agehood to old agehood, or from youth to middle agehood, or you're transitioning from, you know, having dependent children to now having children who are off in college. And so the goals of IPT are to facilitate the mourning process, and it helps the patient reestablish interest in relationships that can fill the void of what has been lost. And so you acknowledge that it is a loss and you are grieving. And this is something also from a CBT perspective that I do, you know, talk about with my patients when it's applicable, because, you know, many times depression does result from these losses, these transitions, you know, like you identify yourself, we identify ourselves in our culture very much with our job and our role in those jobs. And so losing a job is a loss. You know, you want to mourn that and mourn those dreams. And so, you know, it's understandable that you're feeling sad or down, but how can we then, you know, fill that void? And it's not to say that we should forget it, and we should definitely, you know, give ourselves the opportunity to mourn, but at the same time, we then have to learn to move forward as well. There are also role disputes, and then those occur when patients have different expectations of their relationships with other people. So this is often, you know, in a coupling relationship with their significant other, their spouse, their children. And so in IPT, you help the patient identify the nature of the dispute, decide on a plan of action, and begin to modify unsatisfactory patterns, reassess expectations of the relationship, or both. So again, this is a very kind of cognitive therapy similar technique. This is very similar to what I would do using a CBT focus. And then role transitions are similar to kind of the bereavement, but depression associated with role transition occurs when a person has difficulty coping with life changes that require new roles, like a new romantic relationship, transition from high school, college to work. So role transitions in depressed people are often experienced as losses rather than opportunities. So, you know, somebody who is graduating high school and going on to college focuses on losing, you know, the friendships that they had in high school, the safety that they had living at home, whereas somebody, you know, who views it as an opportunity would be excited about the opportunity to be on their own, to learn new things, to meet new people. So in IPT, the role transition, you help the patient give up the old role, encourage expression of the accompanying feelings of guilt, anger, and loss, which are normal in giving up old roles. But then you want to, as much as possible, get support from other people, facilitate acquisition of new skills, and develop a new social network around the new role. And similar as in many conceptualizations of cognitive therapy, there are interpersonal deficits that may go into the development of depression. So, people who have depression may have problems making friends, beginning romantic relationships, forming social ties, making choices about romantic commitment, vocation, sexuality. So IPT helps the patient identify specific roles and deficits in the current and past relationships and consider what needs to be changed. Then using kind of a lot of skills-based techniques, you can work on developing these and focus on developing new relationships, practicing these techniques. So the middle sessions of IPT focus on addressing the specific major problem areas, and then utilizing specific techniques to address issues such as acceptance, establishing relationships, skill building. So again, very similar to CBT. So here you are encouraging the expression of affect if they're kind of avoiding situations where affect needs to be expressed. Clarification, communication analysis, this is where you're looking at how they communicate and then teaching them new strategies. Use behavioral techniques like behavioral activation when necessary, scheduling activities, and then using other methods to reduce depressive symptoms and improve social and interpersonal relations. So depending on your client's specific needs, you would address a lot of that. And then the final sessions focus on termination of therapy, review of treatment, and relapse prevention. So you can see that the conceptualization is slightly different and a little bit more dynamic-y, but ultimately in practice it will look much more similar to CBT. But you can see, for certain patients, and again, I've used many of these techniques in working with my own patients, these, especially for patients that have relational difficulties, these techniques can be very useful, and I've applied them accordingly. So how is this different from traditional psychoanalysis? So unlike traditional psychodynamic approaches, IPT is brief. It's usually 16 sessions, which is why one of the reasons why it has been kind of studied is that it's relatively brief and it can be evaluated more easily than longer-based treatments. It's focused as you're not treating the entire person, but you're generally working on 1 to 2 problem areas. And you're focused more on the present in terms of the current relationship and current social context. You don't explore the deep-seated sources of the symptoms. And the goal really is to have rapid symptom reduction, improve social adjustment, and it frequently leads to more satisfying relationships in the present. So you're not spending a lot of time focused on a lot of the historical factors. And one of the last things I want to talk to you about today is CBASP. I'm not going to spend a lot of time, I just wanted to make you aware of this. This is Cognitive Behavioral Analysis System of Psychotherapy. This was developed for people with chronic depression. So, in the old DSM, this would have been dysthymia. So people who have, or depressive personality disorder type of, symptoms. And traditionally, chronic depression was really hard to treat, and it wasn't really, very effectively treated by medication or psychotherapy. I know that some people have speculated that people with chronic depression, it really is more of a personality disorder, kind of like the my professor would always call it, kind of like people with Eeyore, kind of a little depressed, always looking on the glum side. Those people that are kind of like the glass half empty people. So CBASP is designed for people with chronic depression, which is depression lasting 2 or more years without adequate treatment, and it can become a lifetime problem. There are approximately 20 million chronically depressed adults in the U.S., and it costs us about $40 billion annually in terms of work productivity and absenteeism. It was developed by James McCullough, and it synthesizes writings from a lot of different theories: Seligman's hopelessness theory, Bandura's social learning theory, Piaget's theory of cognitive emotional development, and B.F. Skinner's behavioral models of contingency and reinforcement. Right now, it's one of the only treatments designed to treat chronic depression, and so it really talks about the kind of the retardation of development because of cognitive emotional trauma, and that it's really kind of moving this, and I don't mean retarded in the developmentally delayed sense, I mean kind of like that their emotional development has been kind of stunted, and it's kind of moving them from Piaget's pre-operational to an operational level. So those people who have late onset depression also have kind of unresolved issues that can be addressed with CBASP. And so CBASP has effectively treated both early and late onset types of chronic depression. And so right now, based on the current research, a combination of CBASP and antidepressants is the best course of treatment for persistent depression. It's strongly recommended that all patients who begin CBASP also begin antidepressant medication therapy. And similarly to IPT, the focus really is on their interpersonal behavior and how that behavior has certain consequences in their lives, which then kind of reinforces the depressogenic environment. Like if people are depressed at work, they're not going to get promotions. They may even get fired because they're not overly productive. They push people away from them because, nobody wants to be around a glass half empty, wet blanket kind of person. So you help the patient recognize the consequences of their behavior and then help them kind of reconnect with their environment. So the first goal of CBASP is perceptual connectedness, meaning that the person becomes accessible to formative feedback from the environment. So they start to look at, how their behavior is affecting those around them. And you do this using a technique, in a situation analysis. In situational analysis, the therapist directs the patient's attention to the effect of his or her behavior upon other people, and then you do that in session by showing them how their behavior even affects you. You can say that, when you come in here and you don't look me in the eye and you kind of, my energy drops. It makes me feel like you're not interested in being here. So this can be kind of challenging because you're providing somewhat critical feedback to somebody who is depressed, and we're usually, trying to make, people feel better. And especially with depressed patients, you want to be careful not to overly criticize, but you have to do this in kind of a feedback related way. You also have to explain to them ahead of time before you do this, obviously, the purpose of this, and they have to be willing to accept this kind of feedback. And so you teach them methodically how to overcome some of these skills. So these are a lot of deficits that these people don't have. I haven't worked with a lot of chronically depressed people clinically, but what I've seen, I did a lot of evaluations for for pharmaceutical trials of people who were depressed, and I would see a lot of these people who were chronically depressed, and many times these people have a lot of skills deficits, and so a lot of just teaching them how their behavior affects other people, teaching them basic, social skills, things like that can be very helpful in improving their overall feeling. They generally tend to feel, hopeless and helpless, and so situational analysis can also be seen as an effective way of combating these vulnerabilities and giving them a more internalized locus of control, kind of feeling like, the world is not an out-of-control place, that they have some control over it. The coping survey questionnaire is another method that's used in CBASP, and it's used repeatedly over the course of treatment. And the specific treatment goal is not so much to help patients solve a particular interpersonal problem as to kind of approach problems in a new way. So oftentimes with people who are chronically depressed, there's not one reason for it, they just kind of are that way. And so, you want them to generalize the techniques that they are learning, and so that they can apply them to their life in general to improve the quality of their life. The goal here is not to, make them 100% better, because people who have chronic depression often don't ever fully recover, but rather to kind of improve the quality of their life, whereby, before they were having difficulty functioning, now they're functioning at a much better and higher level. The patient completes one or two of these situational analysis questionnaires each week and brings them to therapy session, and so you spend a lot of the therapy session going through, how the individual's behavior is affecting those around them, and they have to learn how to do this on their own and start analyzing their own behaviors and the effect of their behaviors on other people. And similar to kind of CBT, it's really important for the patient to do the work on their own, very similar to the DTR, because you want them to start analyzing their own behavior and being able to do this kind of in vivo situations. The second goal is to help the patient generate empathic behavior with the therapist and other people. So oftentimes when people become kind of chronically depressed, they become, and I don't want to use the word selfish in a negative term, but they become very self-involved. Their focus is very much on their feelings and their negativity. And so understanding how people, maybe have tried to reach out to them and they've been rebuffed, and how that makes them feel. And so having empathy for those around them, getting out of themselves. And you do this, in the course of treatment and saying, how do you think I feel? And, have you asked me about how I'm feeling today and how, things are going on in my life? The third goal is to heal the interpersonal trauma patients bring to treatment. So this has been going on for a long time. This is going to be very much internalized and has probably become a core belief for them, although that's different terminology. But you have to start healing that and kind of getting, having them challenge some of those core beliefs and healing relationships that they've broken. And you do this through the interpersonal discrimination exercise. Whereas assume that experiences in early relationships will contribute to difficulties in current and future close relationships. So similarly to the core belief, they've probably had some trauma early in childhood, which has then led them, to develop these depressogenic beliefs. Likely many of these will manifest themselves in the therapeutic relationships. So rather than seeing these things as a problem in therapy, you do them as behavioral experiments. So you're using the therapy kind of as a milieu for them to practice a lot of their skills building techniques. And you want them to, use this relationship to actively challenge and update dysfunctional earlier beliefs. So early in treatment, the sufferer makes a list of up to 7 people who've had the most influence in them in their life. And this could be positive or negative, and then you kind of follow through as to what direction their lives have taken because of the interactions with these people and the kind of person they are and how they think, feel, and behave and relate because of their interaction with this person. And so you kind of interrupt their storytelling and help that individual kind of make these cause and effect links for themselves, kind of teaching them their learning history and how those relationships have kind of caused them to be who they are today. And then you talk about how this then these have evolved into these interpersonal themes of I am not worthy, or I am a loser, or I am not loved. And then you then focus them on one of 4 pre-selected domains: intimacy, failure, need, and confrontation. And then these become targets of your therapy. And you kind of show how these themes that the person has developed, kind of these core beliefs, forgive me for using my cognitive therapy language, now are manifesting themselves across these various domains. So the 4 interpersonal domains that are targeted in CBASP are moments of intimacy when the patient opens up emotionally to the therapist, when the patient makes a mistake or fails in some observable way, times when the patient expresses emotional needs to the therapist, and when the patient expresses some negative affect toward the therapist, either verbally or non-verbally, like frustration, anger, and shame. And these are very much in-situation learning experiments that you can practice with the individual. You'll see here that the therapy relationship is extremely important because in many cases, many of these people have pushed others away, and so this might be one of the few relationships that they have. And so you can really kind of work on a lot of the issues that they're having with other people within the therapeutic context. So whenever some of these situations come up, you then work on them in therapy. So you encourage them to compare and contrast your behavior with those of how their significant others reacted. And so you can show them that, while this happened in one domain, it's not always going to happen this way, and how they can then take charge of the situation and change the course of that interaction. And then the 4th goal is the contingent personal responsivity. And that's kind of therapy interfering behaviors to pull from DBT, but it's where you're focused on kind of addressing behaviors that are impacting the therapeutic relationship, but that those are probably also things that the person brings to other relationships in their life, like avoidant behaviors or sarcasm that can be negative, not addressing the elephant in the room, etc. So that's a kind of a brief overview of CBASP. If you're interested in learning further, I would suggest that you purchase the book. You can also attend trainings on CBASP, but it's for use with this very specific patient population. It's a more longer-term intervention, as this is a more kind of long-term type of disorder. And we're going to finish our lecture today by talking a little bit about bipolar disorder. what I find interesting is unless you've really experienced somebody in a manic state, it's very difficult to understand what it's like to be manic. I mean, somebody who's experiencing mania is, on this incredible high, and it can get to the point where they actually, start having psychotic thoughts. One instance that kind of was recently in the media would have been Charlie Sheen. A few years ago, he kind of went off his rocker and started talking about, I forgot everything, but if you watch his YouTube videos, those are kind of a prime example of somebody who's in a manic state. They start making up words that don't necessarily make sense anymore. One of the problems is people who have mania, they like their hypomania. It kind of makes them feel alive. And when they're on medication, they feel blunted and they feel like they've lost part of themselves. But here's patient-defined mania. Nothing is more addictive than the high of a manic euphoria. Once you've tasted that soaring, exhilarating, invincible, phantasmagorical feeling of it's great to be me, I can do anything. Once you've experienced the rush in your mind and overdrive, the creativity pouring through it, the connectivity of burgeoning lateral thinking, the ridiculous ease of witty repartee, the unutterable knowledge of your own immensity, your own infinity, then life without another mania is a dreary prospect indeed. So one of the issues that you have to contend with in working with patients with bipolar disorder is that it's very hard for them to give up this, this manic state or ideally hypomania. I have to say that in some caffeine-induced states, I've experienced a little bit of hypomania myself, and it's incredibly pleasant because you become much more productive, your thoughts are more focused, you have, the juices, the creative juices tend to flow. A lot of people who have bipolar disorder tend to be actually very artistic people, and they tend to be very productive when they have their manic states. And they find their depressive states to be kind of good for the development of content for their manic states. Currently, our first treatments for bipolar disorder are medication. Unlike some of the other disorders where there's debate as to whether it's nature or nurture, bipolar disorder is very much seen to be a biologically based disease. There's a lot of heritability, so oftentimes when you're doing, a history, you want to assess whether people have, first or second degree family members with bipolar disorder, because that increases the risk. Treatments used to include lithium, but lithium can be very toxic, and it has to, you have to go for blood work regularly. Therefore, people can suicide or commit suicide by overdosing on lithium, so it's not a first-line treatment anymore. Now people are using kind of anti-seizure medications, Depakote, valproate, and then adjunct therapy is where we come in as psychologists. So one of the things we want to do with a patient with bipolar disorder is make sure that they're on their medications, because without their medications, they can experience the high highs and the low lows. And oftentimes, one of the diagnostic criteria for, a manic episode is, or part of it is ending up in the hospital. Many people become manic to the point where they are a danger to themselves or others. They kind of become psychotic, and therefore they have to be hospitalized. Like a little bit of hypomania can be good, but when they get into that manic state, it can be actually very, very dangerous. So you want patients to minimize the stress in their lives so to kind of maintain that balance. And that can be done in individual therapy or family therapy, and helping sometimes the families understand what the disorder is like and helping them, support the individual with bipolar disorder. In individual therapy, you want to talk about medication non-compliance. You can use cognitive therapy to increase medication compliance. Other adjunctive therapies include family marital therapy and family-focused therapy, where you're talking to the family about bipolar disorders, problem solving, dealing with resistance to the illness, working on communication skills and problem solving. Unfortunately, right now, psychotherapy probably isn't seen as the first line of treatment for those with bipolar disorder, but it can be very useful in helping people cope, so if they are mourning the loss of their hypomania or mania, but helping them understand that in order for them to function in society, that they need to then maintain this kind of more homeostatic existence, which can be difficult for people who, enjoy their mania. People with bipolar disorder do have an elevated risk of attempting and committing suicide, and therefore it's very important to monitor this if you're working with somebody who has bipolar disorder.